Good afternoon and good morning, everyone. Today is another session of Grand Round, and we are honored to have Dr. Masashi Tamura, whom we have been with over the last 10 days, and it's been an honor because we've been learning a lot of good stuff. So he's an associate professor from Keio University, and today he's going to give us a talk on endovascular treatment of hepatobiliary and pancreatitis, a test-based approach. You're warmly welcome.
Thank you for introducing me. Good afternoon, maybe, and good evening, US. I'm not sure. Good morning. Good morning. I'm sorry. And I'm deeply honored to be here today at Tanzania. I would like to express my gratitude to the organizers for inviting me to be here. And I'm very happy to be here to share my experience with passionate young fellows in Tanzania. And my name is Masashi Tamura from the Department of Radiology at Keio University. And today I will be discussing percutaneous embolization of hepatobiliary and pancreatic bleeding. So I have no COI. And to be first, I'm the interventional radiologist, 60-year experience. And I have been serving as the chair of junior section of JSIR and the specially appointed director of JSIR. And I have family, a wife, and 3 sons. And so now I'm very busy in growing up my child and raising my child and working as a consultant in my university. So the bleeding in the hepatobiliary pancreatic lesion is one of the most common indications for interventional radiologists. And an analysis conducted at Keio University Hospital on bleeding cases in this region from 2008 to 2024 revealed that 185% underwent percutaneous endovascular treatment to achieve hemostasis. Post-operative bleeding was the most frequently observed, followed by iatrogenic bleeding from non-surgical causes, such as liver biopsy or something like that. In today's lecture, I will discuss 4 key points. First, pre-procedure imaging evaluation, and the second, bleeding point detection, and number 3, cover stent placement, and number 4, compressed vascular anatomy of pancreas. So first of all, let's move to the first case. From the left, we have an image of plain CT and arterial phase and the portovenous phase. So what is the diagnosis? And how would you approach treatment? So this is the patient after left liver lobectomy. Okay, and here's a key image. On the right side of the liver, there's a large hematoma. And in the arterial phase, multiple sites of bleeding to be a patient. Diagnosis and how to treat. So before moving to the explanation of the first case, let's take a look at the image for the second case. The patient presents with similar findings. There is a large hematoma adjacent to the right lobe of the liver due to a ruptured hepatic metastasis from right ovarian cancer. Arterial bleeding is bleeding here, and the portal veins remains patent. So we do an angio. Sorry. One sec. Sorry. Once again. You can see in the angiograph images, bleedings observed adjacent to the liver cap cells. However, in the late phase, in the late arterial phase, there is a retrograde flow in the portal vein. You can see. So the ruptured vessel in this case is known as isolated artery. Hepatic artery originally accompanies portal vein and bile duct, and it runs in the Greece but isolated artery is a terminal branch of the hepatic artery that does not accompany the portal vein or bile duct, but is distributed in the hepatic capillary artery network and the hepatic vein wall. So isolated artery is distributed into the hepatic capsular arterial plexus and the hepatic vein bathroom, and some of them going to the sorry. Oh. Shown by the blue, white, and yellow arrow is apparent. And the continuity of isolated artery with the liver capsule is clearly depicted by white and blue and yellow arrow. So in subcapsular liver hemorrhage, rupture of the isolated in subcapsular liver hemorrhage, rupture of the isolated artery occurs. So once subcapsular liver hemorrhage occurs, the bleeding spreads laterally, causing rupture of additional isolated artery. In this way, subcapsular hemorrhage can widely distribute across the liver capsule. So the damage of the isolated artery spread whole liver, sometimes whole liver. Here is an angiographic image of typical subcapsular liver hemorrhage. You can see here. So the percutaneous embolization of subcapsular liver hematoma has so far no consensus of the treatment. Many cases present growing hemorrhage that requires intervention treatment. And because, however, because the time localized embolization is supposed to be inadequate, required, and sometimes it is required that to embolize from the capillary artery plexus fed on extrahepatic artery, such as the inferior phrenic artery. So, however, there is a specific condition that always requires attention in case of subcapsular liver hemorrhage. This is a hepatic compartment syndrome. Hepatic compartment syndrome is a rare but life-threatening entity that consists of a decreased portal flow due to intraparenchymal hypertension secondary to subcapsular liver hematoma. So intrahepatic sinusoid to flow back from the hepatic artery, and the hepatic blood flow in hepatic compartment syndrome is dependent on hepatic arteries. So broad embolization is a high risk of a severe hepatic infarction. In this case, extensive subcapsular hemorrhage was observed along with a retrograde flow in the portal vein. This case can be diagnosed as hepatic compartment syndrome. Due to the patient poor general condition, surgical intervention was not an option, so we proceeded with embolization. We use a small amount of gelatin sponge to preserve hepatic blood flow as much as possible. However, post-procedure, an infarction occurred in the right lobe of the liver. So let's return to the first case. What would be your diagnosis and what would you choose? On close observation of the arterial phase, early visualization of the portal vein branch can be seen. The main portal vein is not visualized yet, so this indicates retrograde flow in the portal vein syndrome and recommended surgical intervention. And post-operative case is very good. So take home point one, pre-procedure dynamic CT is a key for successful treatment, and especially in the liver embolization, check portal vein. And the morphological evaluation of portal vein is not sufficient, but it is important to always be aware of hemodynamics of portal vein and hepatic artery. Let's move into the next case. And this case involves a male patient in his 70s with ruptured hepatocellular carcinoma. He has experienced a multiple rupture in the past. In this instance, another rupture occurred and angiography was performed on the angio. What will be the next step? In case like this, in Japan, we often perform CTHA or Conbeam CTHA as a next step. On CTHA, here, a small amount of extravasation was detected on the surface of the right lobe liver. So after advancing a microcatheter into the responsive vessel and performing a high pressure contrast injection, extravasation was observed using NBCA like this. The next case is patient who went into shock after going a liver biopsy for multiple myeloma and is not on dialysis and requires renal protection. So due to renal impairment, angiography was performed using carbon dioxide. This case allowed okay. Yeah, after embroidering the vessel, we perform the angiography of another vessel here. But again, extravasation was not visible. However, with a carbon dioxide angiography, you can see extravasation here. So carbon dioxide angiography is extremely useful for visualizing extravasation in case like this. I'd like to introduce research from Japan, and CO2 is non-toxic, non-allergic, and highly soluble in blood. And much less viscous than contrast media. And it has also a bus of blood clots. In CO2 angiography, visualized extravasation was not visualized on contrast media immediately after CO2 enhanced by CO2, and CO2 may play some role as a provocative material. So with the carbon dioxide angiography, extravasation was indeed identified. Sorry, this is the next case. This is the next case. This is another case, and multiple HCC rupture, and there is no extravasation in CT, but hemoglobin was decreased, so we decided to the angiography to detect the extravasation. But with the normal contrast angiography, we cannot see extravasation, but in CO2 angiography, you can see the extravasation around here. A little bit hard to see. But the responsive vessels could not be clearly detected with carbon dioxide alone. So extravasation is detected, but from where? Therefore, we use material first, but we cannot detect the embolization. Thereafter, we do a CT-CO2 angiography. From the information from the CO2 angiography, we identified a very small extra CO2 identified. So, and the conventional CTA allowed us to visualize the detailed vascular anatomy. By combining these methods, we were able to identify the responsive vessels and achieved hemostasis using gelatin sponge embolization. So, the take-home point 2, the detection of bleeding point is sometimes difficult in angio, and the CTA or conbeam CTA can detect so tiny amount of bleeding, and the CO2 angiography is very useful detection of tiny bleeding and may play as a provocative role. And the combination of CTA and CT-CO2 angiography is a last result. So this is next case. Sorry. A male patient with a bleeding after post-distal gastrectomy. And you can see the shoulder aneurysm here. And we embolize the ZDA, but very near to the CHA, we still see extravasation. So we continue to embolize GDA, but eventually we inserted a balloon catheter and performed the nephroplasty to continue coronary embolization. However, after embolization, CHA became occluded. This is very sad result. And the next case is also post-PD bleeding case. A shared aneurysm is observed at the ZDA stump. In the delayed phase of the superior mesenteric artery, the visualization of portal vein is very poor. To preserve hepatic blood flow, we inserted the stent graft. A 9 French guiding sheath was placed, and we pressed the stent graft. Sorry, PD, post pancreatic duodenectomy. We put the stent graft. However, hepatic flow was interrupted after placing the stent graft. Despite the multiple balloon dilatation and the thrombolysis attempt, blood flow was not restored. In this case, we had actually used 2016. It was memorable year because it was the year when Vyvanse was approved for insurance coverage in Japan. So before 2016, we have to use biliary covered stent of label use, often failure after the placement. But after 2016, we can use Vyvanse. So the approval of Vyvanse significantly changed endovascular treatment for post-operative bleeding. Since 2016, the use of stent graft has increased to the 34%, and the overall number of interventions has also risen. So this case involved a post-PD patient. Here you can see a vascular injury, both CHA and the SMA. And we put the stent graft to CHA and the SMA. Yeah, you can see the vascular injury here. And we put the stent graft. So this is very not so difficult because Vyvanse is very low profile. So we can easily put guiding sheath to the SMA, so it is not so difficult. So during the post-operative follow-up, the stent graft placed in CHA. However, the SMA remained patent, and the patient continues to take antiplatelet medication. And the hepatic arterial flow was maintained after 2 years and a half, 8 months. So it is enough for stopping and keep maintaining liver function. So according to the report by Professor Inoue and colleagues, technical success rate and clinical success rate of stent graft placement in 20 cases treated at Keio University were 95.2% and 100% respectively, percent at 1 year, 2 year, and 62% and 3 years, respectively. So endovascular repair using Vibrant for hepatic arterial injury after hepatobiliary pancreatic surgery was safe and effective, and the stent graft might improve prognosis patients with bleeding after major abdominal surgery. This is another report from Asan Medical Center in Korea, also demonstrates the favorable long-term outcome with stent graft placement. However, there is no established regimen for antiplatelet therapy following stent graft placement. Previous reports indicate no correlation between antiplatelet medication use and the patency rates. So we also initiate dual antiplatelet therapy as long as the patient's condition perform. Okay. However, stent graft placement poses certain technical challenges. This case involves a shoot aneurysm of the CHA following a distal pancreatic, and the guiding sheath was inserted in the standard manner. And the following post-preoperative measurements, 5 mm and 6 mm stent grafts were overlapped and deployed. However, on immediate angiography, type 1 end leak was observed through the gutter between the patient vessel and the stent graft. Multiple dilatation were attempted for compression, but were unsuccessful. Was inserted into the stent graft gutter, and the gutter embolization was performed. And the post-embolization shoot aneurysm was disappeared. Selecting the appropriate site is crucial for successful stent graft placement. When reviewing the Vibrant instruction for use, the recommended vessel diameter for each stent graft site is indicated. However, the Japanese IFU also includes the following statement: when using adjacent stent graft may be used up to 1 mm apart in diameter. So in this case, 5 mm stent graft was recommended for the distal site, and the 7 mm stent graft for the proximal, not permitted by Japanese IFU. So we selected the 6 mm stent graft for the proximal site. It becomes spastic. Therefore, it and the stent graft was subsequently placed in the standard manner, like this. However, after placing the stent graft, bleeding from the distal graft anastomosis became evident, like this. So further stent graft placement was deemed challenging, so the anastomosis was embolized like this and achieving hemostasis. It is likely that anastomosis rupture occurred due to the insertion of the stiff guide wire V18. So as shown here, stent graft placement requires the insertion of a guiding sheath and a stiff guide wire, which introduce a risk of vascular injury. It is very essential not only to consider vascular anatomy, but also have to thorough discussion with the surgeon to assess whether the target vessel is in a stable condition. So take home 3 or point 3. Stent graft is a game changer of a major vessel injury, and stent graft might improve prognosis of patients with bleeding after major abdominal surgery. And the size selection is the key, and check the vessel diameter precisely. And note that the system insertion itself can cause vessel anatomy. Lastly, let's discuss the complex anatomy of the pancreas. As you know, the pancreas, particularly around the pancreatic head, has an abundant network of collateral arteries. Each of these small arteries often originates from relatively large vessels, such as the celiac artery, supramesenteric artery, and the common hepatic artery, making selective catheterization experience bleeding from J1, from PD, following PD, J1, which aligns very steeply and directly from the SMA here. Due to the difficulty of selecting this vessel with a standard manner, we use the steam-shaped limb catheter for the selection. Using a steam-shaped limb catheter, we can select the artery here. Yeah, clear extravasation was visualized, but we could not only insert the very flexible floppy portion of a 10-inch guide wire. So therefore, we use a diffractor nanocatheter, which allows us to insert a microcatheter into this vessel here. Diffractor nanocatheter is a very highly flexible 1.3 French catheter designed for neurovascular interventions. It offers excellent trackability even in case where only a small portion of the guide wire can be inserted. And the embolization was successfully achieved by NBCA. This is a similar case of bleeding from a small great pancreatic artery branching from splenic artery. Catheter insertion was anticipated to be challenging. The femoral artery approach proved to be unstable. So we switched to brachial arterial approach like this. After inserting a Dynas catheter into the splenic artery, pre-shaped microcatheter. Yeah, this. So without the need of guide wire, we were with its wide variety of tip shape, can be very useful for accessing small vessels that branch at a steep angle. So if necessary, you can make a shape in microcatheter with steam. So if necessary, you can make a stiff by the hot water, and it can change the shape of the tip of a microcatheter. So I will skip this because this is too technically demanding. Okay, so I will skip this. So pancreatic artery is often probably originating from relatively large artery in an acute angle. And the rich collateral pathway can cause rebleeding. So sometimes this artery is very difficult to treat. So use appropriate shaped catheter. Stem shaping is often necessary, and pre-shape and stable microcatheters help a lot for interventional radiologists. And improving knowledge of device is very essential. So if necessary, you have to know neurointerventional device, and this is often very useful. And this is a summary of take-home. Evaluate not only morphology, but also hemodynamically, and be familiar with a variety of means for identifying bleeding points. And the proper anatomical and size selection is essential for stent graft placement, and be aware of complex arterial anatomy, especially in pancreas. So thank you for your attention.
Yeah, Professor. Sorry, there's one part. I think it was a take-home message too.
Mm-hmm.
You mentioned about renal artery embolization. Please take me through that again, because renal artery is an end artery. When you embolize that, what happens regarding the infarction of the organ?
So this patient, man, yes, with venous saphenous vein bypass from renal artery to right hepatic artery. So this is a saphenous vein graft from right hepatic artery to right renal artery to right hepatic artery. So, and the bleeding is from here, the proximal anastomosis of right renal artery and the saphenous vein bypass. We have to stop the bleeding here, but we put stent graft like this. We have to put like this. But if we put stent graft like this, renal artery will be embolized. And maybe you think renal artery is an endo artery, but to tell the truth, it has a collateral from the ureteral artery and capsular artery of kidney. So there can be a end leak from retrograde arterial flow from the renal artery. So I wonder if this is not always necessary, but to prevent type 2 end leak, I embolized the right renal artery to make hemostasis sure for this patient. But unfortunately, because of the stiff guide wire, distal anastomosis was ruptured. So eventually we embolized all of the hepatic artery bypass, and we pressed the stent graft here, but we embolized it. So finally we embolized it, save this patient, I think this is the only way to embroid all of them. So sometimes we have to embroid it. And of course, after this embroidation, patient suffers severe liver function, liver infection. But if we cannot save him in this point, in the future you cannot. So to save life, I had done this procedure.
So how much time do you need to wait after the anastomosis? Wait to cure? Like how much? Some people say 4 to 6 weeks.
4 weeks, I'm not sure, but maybe 8 weeks or more, I think it is okay. Basically, it is often open surgery. So maybe I think 6 weeks is okay, but I'm not sure. So please discuss with surgeons, with the surgeon. So if surgeon says okay, then you can try. But Mhm. Mhm. Mhm.
So you want to do plastic, you would ideally wait until at least 8 weeks, right?
Yes, that's right. But sometimes I have to do angioplasty for the after the liver transplant thrombus occur in very early timing. So, for example, 10 days or 2 weeks or so, and the surgeon asked us to do angioplasty, and I tried to refuse, but in most of the time, I cannot refuse eventually. So I will do very mild angioplasty for the patient. So I have never experienced the rupture of hepatic artery after the little bit lucky. So angioplasty just after the surgery. Any other question?
Yes, I have one. Thank you, Professor, for this
Okay.
talk. I am
So thank you for
Thank you so much, Dr. Masashi.